Hello, I am Karlene Lawrence. I am the co-director of the interprofessional team on the HRSA Bridge GWEP grant on the Geriatric Psychiatry Service. I am presenting Wellness and Functional Ability in the Older Adult. As I mentioned before, we have a grant on our service from the HRSA, which I'll define in a little bit, which from the U.S. Department of Health and Human Services to educate the next generation of healthcare providers to be age-friendly and dementia-friendly in an interprofessional format. And we are educating students from all the schools and colleges here at SUNY Downstate Medical Center. And they are rotating on our service to embrace this new format of healthcare for our older adults or community residents. I do not have any conflicts of interest or financial conflicts of interest. As I mentioned before, HRSA is Health Resources and Services Administration. It's a federal department that is a sponsor of our grant. GWEP, Geriatric Workforce Enhancement Program, is the grant that we have received from them to educate the next generation of interprofessional healthcare providers. Bridge has to do with the GWEP grant at Downstate, so our name at Downstate is Brooklyn Initiative to Develop Geriatric Workforce Education. So this is a GWEP grant from HRSA in Brooklyn at SUNY Downstate. CIAD is another grant on our service. It's from New York State, and it's for Alzheimer's care and also to educate the next generation of healthcare providers, students on our service to better assess and take care of patients or community residents with Alzheimer's disease. 4Ms is the format of the grant, the HRSA grant, and I'll explain that later, but it has to do with the 4Ms are what matters, medication, mentation, and mobility. It's a collaboration between the Hartford Foundation and the Institute of Healthcare Improvement. Bridge IT, which I am the co-director of, is the Bridge Interprofessional Teams Program. So having the students rotate on our service is Bridge IT, under Bridge IT, Bridge Interprofessional Teams. ADRD, which you may also hear mentioned in this presentation or other presentations that we're also developing, is Alzheimer's disease and related dementias. Bridge Gap is also part of the grant. ECHO is a video learning format that we have incorporated into our grant, bringing our partners, our outside partners or other healthcare providers that cannot actually come physically to Downstate, and we have interprofessional case presentations, getting feedback from specialists that are not at Downstate that will help us to solve a problem or an issue that we may have identified with one of our patients or community residents. Self-learning module, which is this, it's a curriculum that we are developing for self-learning, and there are multiple different parts of it, different sections of it, and this topic is one of the topics in the Group A. So it's a Bridge Self-Learning Module, Group A, and these are all the modules in the Group A section, and Wellness and Functional Ability is the second one. The learning objectives for this self-learning module: to recognize the impact of integrating the 7 dimensions of wellness on patient outcomes, that define the multiple components influencing the health and wellness of an older adult or community resident. I use those interchangeably. Identify the 8 multidimensional factors of wellness. Provide examples of the 2 key divisions of functional ability, and demonstrate how 3 of the 6 functional assessment screening instruments that I will be presenting could be used in a primary care setting. This is a model for the 4Ms, which I mentioned before, to develop age-friendly, dementia-friendly care. And as you see, the 4Ms are what matters. The M for that is matters. So we have patient-centered, family-centered care. So the goals of the family, the healthcare goals of the family, healthcare goals of the patient is what's important to us, and we incorporate that into our interprofessional team development of healthcare plans for the patient or community resident. Medication, so each of the 4 M's are interrelated and one affects the other 3. So we assess for medication, and that will be over-medication or polypharmacy, because as we I will explain, having too many medications or being required to take too many medications predisposes to having other issues, which is just as bad as not having enough medication or under-prescribing. Mentation, of course, medication, being over-medicated or having to take or remember to take a bunch of medications can affect mentation and mobility, and definitely that could also affect mobility. Mentation can affect mobility, affects what matters to the patient. Mentation affects all the other 3 M's, and as it goes, mobility would affect what matters, medication, and mentation. So they're interrelated and have an effect on each of the other 3 M's. There are ageism alerts, so we are trying to stop ageism, preconceptions of older adults or community residents. We are also trying to decrease stereotypes, so we as healthcare providers need to examine ourselves and become aware of our own biases and stereotypes that we have for an older adult, and we try to eradicate them. So this is just bringing awareness of some, and as you watch other self-learning modules, you'll see different ageism alerts throughout the presentation. So the first ageism alert, ageism is a complex phenomenon with a burden of social and political prejudices with real costs to health, well-being, and longevity of older adults. So this is a reason to stop ageism, is because it affects our health outcomes of our older adults or community residents. So this is wellness. Wellness includes the following multidimensional factors of health that affects overall health. And this wheel, there are different wheels, but I like this wheel because of the color and because it actually explains each aspect of the wellness wheel, is physical, mental, intellectual, emotional, spiritual, social or psychosocial, financial, occupational, and environmental. And you can see this mirrors very closely the objectives of the 4M framework. So physical wellness is not just being free of illness or free of disease. It's care of self for optimum health, being healthy, aging in place in the community, staying in and aging at home for as long as possible, through exercise, nutrition, sleep, and other preventive health measures. So wellness is based on preventive health, preventing an illness before it happens, and there are lots of benefits to preventing an issue before it happens. One is decreased healthcare costs. When an illness is identified later on, more advanced, it takes more healthcare resources, more patient time to identify and to treat, and also the treatment or care factors are higher, may not be curable, maybe that advanced that it's not curable, but also just the services that need to go into curing it when it's more advanced. So preventive health wellness is all about preventive health, preventing an illness, preventing a problem, preventing a disease before it happens, when it's more treatable, or never have it happen at all. Mental and intellectual, so interaction through learning, open to new ideas, creativity, critical thinking, problem solving, and seeking new challenges. So keeping our minds healthy. And this is our mentation part of our 4 M's. Emotional, positive attitude, high self-esteem, being in touch with and aware of, accepting of others, ability to constructively express feelings and empathize with others constructively. Spiritual, finding meaning in life events, search for meaning and purpose in human existence, live a life reflecting one's values and beliefs, and demonstrate individual purpose. So spiritual is not having to be a specific religion or a specific religious belief or following a specific doctrine. It has to do with just overall spirituality, being more aware of yourself, what's important to you, and how that affects others, your community, your environment around you. And that's also coming up as another of the wellness factors. Social, being connected and interact with others, build personal relationships, deal with conflict appropriately, positively contribute to our communities. So our social or psychosocial wellness affects our overall wellness and most time affects our physical health. So being socially isolated has negative effects on our health, on our well-being, on our functioning. Financial, living within one's means and learn to manage finances in the short and long term. So immediately you are able to manage your finances, but also planning for long term or later on as you age longer in place in your home. Occupational, seeking an interesting, enjoyable, meaningful career that contributes to the larger community. So being happy at work, less stress at work, enjoying what you do, contributing to your community, and fulfills yourself, fulfills your spirituality, fulfills your healthcare and mental health needs. Environmental, awareness of interactions between the environment, community, and individuals. Awareness of our role to improve rather than destroy the natural environment. You see a lot of reports in the news right now about climate change and the influence of that on our weather, on our where we live, where others live. It's like the wildfires right now in California that are out of control. So that's being aware of that and not contributing to that, actually assisting to prevent that. Responsibility, personal actions to obtain or maintain a healthy physical environment free of hazards. So also throughout the presentations, my presentation, other presentations in the series are what's called brainstorms. So these are little learning opportunities. We pose questions for consideration, something you may not be aware of, something you already know, to think about and come up with an answer. So at this point, you would actually pause the video, do the brainstorm, and then you could continue the video. And throughout this presentation, you could pause the video anywhere as you need to. So health and wellness exams and assessments require an interprofessional healthcare team. Interdisciplinary healthcare staff at either initial or follow-up medical visits or healthcare visits may include what staff specialties. So as I said before, our grant is to foster interprofessional interprofessional format of healthcare for the patient and community residents. On that healthcare team, what other specialties could be there? So if I am a nurse practitioner, so I am on the healthcare team. On our service, we have social work, and on the students that are rotating on our clinical service, we have physician assistants, we have medical students, we have nursing, nurse practitioner students, and eventually we hope to incorporate all the other schools and colleges at downstate to have their students rotate on our service. When we go out and practice in our professional environment, we will be part of a patient's healthcare team. So the wellness visit is different from a problem-focused visit. So we actually are entitled by our CMS, the Centers for Medicaid and Medicare Services, to have an annual wellness visit at once a year. That should be free of a copay. So you could go in, you could schedule an annual wellness visit and have that done at once a year. That is allowed. Most institutions may combine that with a problem-focused visit, but it doesn't have to be. And so problem-focused visit where we go to see our healthcare provider with a problem, with an issue. So something adverse is happening. We have a headache, our blood glucose is out of control, we have pains in our legs. So that would be a problem-focused visit. So the reason we're going to see coming to see us, healthcare providers, because there is a problem. So that's a problem-focused visit. This is an annual wellness exam. And the difference between the problem-focused visit and the annual wellness exam, the most important is that there is no physical exam at an annual wellness visit. It's for preventive health, preventive healthcare education and teaching, for screenings, for vaccinations to make sure that adults are up to date, because adults also get vaccination, not just children or teenagers, but older adults are also, there's certain vaccines that we should be getting also. So an annual wellness exam is a preventative health exam. The only physical part of it is having the vital signs done, the temperature, blood pressure, calculating the body mass index. That's the only physical part of it. The rest of it is, as I said, teaching, screenings, vaccines, teaching the family, speaking to the caregiver, developing a relationship, having their other questions answered that's not related to an acute illness or acute condition that's happening with them. So we have, of course, past medical history. We have history of present illness, what's happened with them since the last time we saw them. And again, no physical exam, but we do vital signs. And if the vital signs are abnormal, then it changes from an annual wellness exam. It becomes a problem-focused visit, and the annual wellness exam would be rescheduled at another time. So we're not ignoring abnormals that may come up from having the vital signs done. Cognitive capacity, neurology, respiratory, so we go through all the systems. Functional ability, are they able to independently take care of their independent activities of daily living, or their daily activities, or their regular activities of daily living? And I will address that later in the presentation. So their functional ability, their functional status, again, polypharmacy. So polypharmacy is not only done at the annual wellness exam, it's supposed to be done every visit, even a problem-focused visit. We should do a medication reconciliation. So every visit, every time, we should do a medication reconciliation, having the patient tell us what medications they're on, not us telling the patient what's on our electronic medical record. And if the patient cannot pronounce it, have them spell it. We need to know the names. We need to know the dosages, milligrams, micrograms, drops, units, and the interval that they're supposed to be taking it. A lot of patients or community residents, from doing the medication reconciliation, realize that they're not taking it at the right interval that's prescribed. And also it's a catch, a less embarrassing catch, of patients that are of low literacy to no literacy, or patients that are unable to read their primary language. So if English is not their primary language and the medication is in their primary language, but they're still unable to read the label, that does not help the patient. So this is also a catch. From doing medication reconciliation, we're able to identify patients that are unable to read their primary language. A screen of nutrition, is there food insecurity? Are they able to prepare or have a balanced meal at least once a day, the minimum, but hopefully more? Gastrointestinal review, when was your last colonoscopy? So age-specific health screenings. Are they still sexually active? And yes, older adults and community residents are still sexually active. An older adult is defined as a person age 55 and older. A senior is defined as a person age 65 and older. That's where you get your benefits. You start getting your Medicaid benefits, your your bus passes. So that's considered a senior, that's 65 and older. But adults 55 and over are considered to be older adults, and yes, they're still sexually active, so we need to screen them, find out if they are they practicing safe sex, if they've had a sexually transmitted infection, has it been treated, is it untreated, because that could also affect mentation. So that's why we're also doing this screening, and of course teaching education. Musculoskeletal assessments, are they, again, coming back to function? Do they require assisted devices to get around? They're having balance and gait problems. Are there risks for fall? Do they have a high risk for falling because they have balance and gait problems? Are they supposed to be using assistive devices but may not be using it, or maybe it's not in functioning working order? Osteoporosis screen, strength, incontinence or urine incontinence and fecal incontinence of bowel and bladder. Are they wearing incontinence underwear? Are they required to wear incontinence underwear? And that also affects sleep. If they're getting up at night, nocturia, to go to the bathroom, that's affecting their sleep and decreasing their restful sleep. Their psychosocial environments at home, what is happening in their house, which I'll cover also. Their sexual health, which I just mentioned. Their functional status, which is different from their functional ability. Employment and finances, what's happening there? Are there issues? Are there deficits? Again, preventive health and wellness, teaching, education, spirituality, coping. What's their coping system? Do they have support How do they cope with stress? Is there someone they could speak to, or do they need us to, as the providers, to make referrals and provide other resources for them? And family and leisure, most definitely important. Sleep hygiene, as I said, most important. Their mental health, we screen for mental health. Life stressors, relationship problems, sexual health problems, or just sexual health in general. Employment and finances, the dynamics of their family. Are they the primary caregiver? Are they living alone but they need more assistance? Are they able to take care of themselves while living alone? Are they at risk for domestic abuse and violence? Are older adults, seniors, are they being neglected, receiving emotional, verbal, or for physical abuse, actual physical abuse? So that's a screening for that also. Eating disorders, use of cigarettes, alcohol, illicit or illegal substance use or abuse or dependency, support system, as I said, who is their support system? Do they have a support system? If they don't, do they need to have, should they have a support system? Maybe we need to refer them to other resources. How are they coping? And counseling and referral as indicated by all the screening that has gone before. So these are the components of an annual wellness exam. It is a longer exam, and it needs to be scheduled by your practice as such, because as I said, it does include screening, everything else, and of course patient teaching and education, and periods for questions and answers from the patient and caregiver or the family. This is our review of system that we use on our service. So patients come in, every visit we screen them for what's happening, and this is entered into our electronic medical record. So this is one example of a screening tool that's used, or screening instrument that's used for with interval visit from the last visit to this, what's happened, to compare what's happened. Is there been a deficit or increased deficit, or has there been an improvement in the patient's condition? And it goes, as I said, it's a system review, so from head to toe system review, including severe stress. Functional status assessments are professional observations, so what we observe while speaking to the patient, while speaking to the family or caregiver. Tests or screenings that we administer, and also self-reported incidences or from the patient, proxy, caregiver. And so use to guide therapy, design coordinated services, again we're an interprofessional practice, and monitor persons with various chronic conditions. And also to develop, to help the patient develop their healthcare goals. A lot of patients are not used to hearing that, so we want their input on developing what we call a plan of care, but should be their healthcare goals. Functional decline is a need for assistance in at least one basic physical or cognitive activity, such as walking, focusing attention, the routine activities of daily living, which I'm going to cover again, which are eating, bathing, picking your clothes that's appropriate for the season, being able to put those clothes on themselves, transferring from bed to chair or from the toilet back to chair or toilet to standing, life situations I mentioned before, such as employment, living independently if they still can, and managing finances. Functional status is the most important determinant of quality of life for older adults, and independence in performing activities of daily living and independent activities of daily living include the related concepts of functional capacity, as an individual's ability to perform the activities of daily living and their independent activities of daily living, and functional performance, which is again a self-report of patient telling us that measures an individual's ability to perform these tasks independently with supervision or with assistance, and live on their own, or be active in their community and in their homes, aging in place. So functional ability is a person's potential or capacity to perform tasks required for living. And I mentioned before, the healthcare assessment of an older adult or community resident should include review of these key divisions of functional ability. Activities of daily living, which are also called basic activities of daily living, which are self-care activities. Instrumental activities of daily living, which are independent living activities, and they're broken down further, and I will present those in a little while. And advanced activities of daily living, which are psychosocial roles and tasks. Activities of daily living, or basic activities of daily living, those are the acronyms. The ability to perform basic self-care tasks of eating, feeding yourself, preparing your own meal, dressing, bathing, being able to turn on the water, regulate it, actually lather, bathe, rinse properly. So all of the facets of bathe or taking a shower or bathing. Bed to chair transfer, toileting, again, being able to go to the bathroom, use the bathroom, and clean up or wipe yourself after appropriately. Bladder and bowel continence or incontinence, and control functions or dysfunction. So we assess this is the person, the patient, or community resident able to perform these independently? Do they require some assistance? Do they require supervision, or are they totally dependent? Deficits in ADLs and IADLs can signal a need for in-depth evaluations or further evaluation of the patient's social environmental circumstances and need for additional assistance. And listed here are some of the screening tools that I'm going to present, including the ones that we use on our service. So this is our activities of daily living screen, and this is administered, as I said, every visit the patient comes in. And this is a self-report by the patient or their caregiver or whoever is there with them for their social support, their healthcare proxy even. So bathing, grooming, toileting, dressing, moving, transferring, self-feeding, as it says, not cooking. But sometimes we actually do assess cooking in the IADLs. Are they able to cook? Do they forget to turn the stove off? Do they leave the stove on? So that's also assessed in the next instrument. So these, as I said, is independent. Are they able to perform these tasks independently? Do they require supervision or total assistance, or totally dependent on someone else to help them with these tasks or perform the tasks for them? The CATS Index of Independent in Activities of Daily Living is another ADL screening instrument. It's scored from 0 to 1. And that score of 6, which is the highest, and 0 being low, indicates, so 6 indicates the patient is totally independent, and 0, as we go lower from 6 towards 0, the patient is more dependent, or to finally being totally dependent. So this is just another screening tool that you may encounter in your practice. Instrumental activities of daily living are independent living activities such as performing housework. Are you still able to perform your chores at home? Preparing your meal. So this is where cooking comes in. Do you leave the stove on? Do you forget to turn it off? Do you forget pots on that are on with the flame on underneath it? So these are another assessment. Taking medication, so being able, if you do have assistance and somebody does lay out your medication for you in the little pill packs, do you remember to take it on time? Are you being adherent to the timing, the intervals? Managing finances, paying your rent, paying your mortgage, paying your bills. Do you remember to pay your bills, or do you forget until the electricity is disconnected? Using a telephone, so that's initiating a telephone call and picking up and answering a telephone call. So these are the instrumental activities of daily living, and this is our services screening instrument. So cleaning, maintaining the home, which is exactly as we said before, handling finances, preparing meals, medications, transportation, using telephone, shopping. Are you still able to go out and shop for yourself, buy your own groceries, laundry and dressing, and also which I would mention in the other, is also navigating the stairs. Are you still able to navigate the stairs? And that impacts your fall risk. You should not be navigating the stairs, or can you still independently, or do you need assistance navigating the stairs? And that's indicated on here. So Barthel's activities of daily living, this one does include stair navigation. Okay? So this is just another format. Scores 10 items, a maximum score of 100, and 100 being the highest, and indicating total independence. Lawton Brody, instrumental activities of daily living. So this is more detailed. It's broken down. It's actually on 2 pages, and it asks the same criteria that we covered before, but in more detail. So ability to use the telephone, we have 3 different criteria. Does not make phone call, answers a phone call, dials, so it breaks it down. Shopping on your own, food preparation, that includes planning your own meal, housekeeping, and laundry. So this is page 1. And page 2, are you still driving? Should you still be driving? How do you get around? Maybe a social worker on your interprofessional team could give you resources or instruct you about applying for Access-A-Ride. Some insurance companies actually offer car service as part of your benefits, something to be aware of. But also that's a discussion to have is, should your parent, your person that you are the healthcare proxy for or you're the caregiver for, should they still be driving? Being responsible for your own medication, and again, your ability to handle your finances. Another one of the 4 M's is mobility, and that involves balance, your gait, not just your mobility, and that affects your mobility. So this is a screening test. It's called the Get Up and Go or Time Get Up and Go, which are similar, except that the Time Get Up and Go, you're able to complete this activity in a certain time frame. So you're asked from sitting, you stand, walk a straight line, turn around, and walk back and sit down. And it's timed, and as you can see on the left, less than 10 seconds is free mobility, no issues, no deficits, and greater than 30 seconds would indicate assisted mobility or assistance needed in your mobility. So this is a Tonetti balance and gait evaluation, and again, it's broken down. Sitting, are you able to sit without leaning off to the side? Are you able to stay steady? Are you able to sit on your own without assistance? How do you get up from the chair? Do you have to hold on to get up? Can you get straight up from the chair? How many attempts? Sometimes you see people that need to rock back and forth to get started. Immediately standing, and it's time in the first 5 seconds. Your standing balance, are you steady or unsteady? Again, are you listing off to the side? Are you able to maintain your posture? With your eyes closed, are you still able to maintain your postures? Are you drifting? Can you turn complete 360, a complete circle without falling over? So this is the Tonetti gait balance and gait evaluation. This is in 2 pages, very detailed, page 1 and page 2, which is foot, how do you walk? So this is assessing your gait, what happens when you walk. And then on the bottom is the scoring. Less than or equal to 18 is a high risk for falls, and you can see how it's scored on the bottom. Cognitive function screening, which is part of one of the 4 M's, mentation. So at every visit, every patient that comes in, our new patients, our follow-up patients, this is our screening instrument for mentation, memory and cognition. And this is a mini mental status exam. You may have heard mini mental state exam, the MMSC. So this is our MMSC, and it's pretty straightforward. It has all the instructions on how to administer it. So we ask the patients, do they know what year, season, month, and each of the points that are answered correctly get 1 point, for a total of 5 for each of those lines, for each of those questions. The thing about this, if there's a caregiver present or family member present, you advise them not to coach the patient, because they want the patient to do well because they think it's a test. So you coach them. It's not, so what year is it? Not like, is it 19, is it 2019, is it 2018? This is just for the patient. This is the only thing in our practice where we only want the patient to answer. All the other questions and everything else that comes after, we want the caregiver to verify or give collateral verification, but this is for the patient to answer. And as it goes through, so if the patient is unable to complete this, we then assess them, are they alert and oriented ×3? So if they're not able to answer this for various reasons, including low literacy or no literacy, then we would assess them, are they ANO ×3, and document that. This is a clock drawing, and this is what we hand to our patients or community residents with the instructions to put the numbers on the clock as it normally would appear, put the hands on the clock, and have the clock indicate 10 after 11. And this is what they're given. And to score that between 1 and 3, 1 being the highest, 3 being borderline to abnormal, you could see at 3 it's not as what we expect, but most of what we require is there. And then as it gets further down towards 6, so 6 would be abnormal or indicate a need for further evaluation or intervention. So this is a clock drawing. And of course, a geriatric depression scale. So we need to assess our patients for undiagnosed depression because it affects so many aspects of their lives. And as far as the 4M's go, it affects all 4M's. So this is one scale. It's not the only scale. So this is a form of a geriatric depression scale. You may see others in your practice. And we just ask these questions, and depending on the score, that indicates diagnosis of depression, or it may, and also a requirement for additional services or additional interventions. This is our depression scale that we have on our service. This is so it's part of the mini-mental, the review of system function, the ADL, IADLs, and we also give them this. So each patient and their caregiver, this is also a self-reported scale. Do you have any of these? And there's 2 pages to this. Does it never happen? So yes or no. Does it happen several days or nearly every day? And these are the criteria that we're screening for. And then page 2, and it's yes or no, or Y or N that the patient indicates. And we go back to, so bringing primary care into our service. Have you had a medical checkup? So I ask each patient who their primary care provider is. And if they do have a primary care provider, when was the last time they saw that primary care provider? And do they think they have the help that they need to function in their home, or to stay independent in their home? And most important is, how would you rate your physical health? So after patients tell us everything that we're asking them on the instruments, we have an opinion of what their health may be, but it's also really interesting to see how they rate their health. And again, our healthcare plan, their healthcare goals should be a cooperation to help them achieve what they think they have, or to improve what they have now to what they actually believe is happening with them. So advanced activities of daily living is the ability to participate in or fulfill societal roles. So your role in the community, interaction in the community, not being isolated at home. Your family role, what is required of you? Do you need assistance? Are you the primary caregiver? Are you the grandmother that's taking care of your grandchildren for whatever reason? You need assistance with that. Recreation or occupational tasks, most important. A lot of patients and community residents sometimes get so involved in what's happening in their homes, or whatever crisis is happening in their homes, that they forget to take care of themselves. So we remind them, and we give them assistance, resources, and referrals to help them get back in touch with what's important to them, and also realize that it is important to take care of themselves also while taking care of everybody else. Another brainstorm. So this is a little long one. So a functional assessment is an interdisciplinary diagnostic process to assess and quantify an older adult's blank status. So a functional assessment is an interdisciplinary diagnostic process to assess and quantify an older adult's functional status. So that's what we're assessing for. And information that we acquire or we gather from that is used by whom, or to develop a comprehensive plan of care and future care decision. So who would use the information from the functional assessment to develop a comprehensive plan of therapy and future care decision? It would be any person on that patient or community resident's healthcare team that could use that information. I spoke about polypharmacy before, one of the 4M's. Diagnosis of the reason for having polypharmacy and as an issue right now with older adults and community residents is that they have so many multiple medical comorbidities, and their healthcare is not centralized. Sometimes we are the only provider for that patient at SUNY downstate, and their providers are at different facilities. So we try to have to coordinate care and have those other providers send us a list of the patient medication, but also by asking the patient what exactly they have in their shopping bag at home, what are they taking daily, also helps us to coordinate and do a pretty good medication reconciliation. So polypharmacy results in adherence issue, of course, for older adults, not just for older adults, but for most persons that are taking many medications, keeping up with the intervals and dosage. Polypharmacy is defined as 4 or more medication daily, and that includes prescription medicines, over-the-counter medicines that we advise patient or community resident to take, or that they have bought and started themselves. Herbal or nutritional supplement that they may not consider medication, but we want to know because there are interactions between over-the-counter medicines, some herbal supplements, some nutrition supplements, and prescription medicine. So we want to know exactly everything that they're taking. And our aim is to de-prescribe unnecessary medications for older adults, to limit polypharmacy. So if they're taking 3 medications to treat constipation, that would come out in a medication reconciliation. Hopefully we could decrease it to 1, or if maybe there's a medication that we could completely eliminate to prevent the constipation. But while we're trying to de-prescribe and cut down the number of medications that older adults, our patients and community residents are taking, under-prescribing is an issue that we should try to eliminate. So that's when we think that because they're older adults, or they may not benefit from using this medication because of the potential side effects. But we should always remember the adage of starting medications for anyone, but more so for our older adults and community residents, is to start at a low dose and titrate up slowly, observing for adverse medication reactions. Okay. Polypharmacy is associated with increased use, again, of multiple medications, higher healthcare costs, increased risk of an actual medication-to-medication interaction or medication-to-disease interaction. So having an interaction with other illnesses that they may be treating. Medication non-adherence, just keeping track of all the medication timing and the doses, and development of worsening multiple geriatric syndromes. And as I said before, to reduce and eliminate polypharmacy, we should identify, reconcile all existing medications that our patients or community residents are taking at every visit, every time, and evaluate the risk of medications that they're on, or also the risk and benefits of medications that we're starting. Because sometimes patients are on medications forever and they have no idea why, they don't remember why, but they know they've been on it forever, so they keep taking it. This is an opportunity for education and teaching during the annual wellness exam. Another ageism alert, preconception breed misconceptions. So we should identify whatever negative stereotypes we have of older adults, because that is causing ageism and that interferes with our interaction and our treatment for them and our recommendations, our healthcare recommendations for them. Sensory deficits, this is one of the misconceptions that's out there. Sensory deficits, vision and/or hearing difficulty is normal or expected as patients age, as persons age, which is not true. And most older adults are not sexually active, which is definitely not true. Okay? So this is an opportunity for teaching. As I said, when we assess our patients for sexual activity, it's not just to be nosy, but it's also an opportunity for teaching about safe sex practices, make sure they're practicing safe sex practice, they know what that entails to keep them healthy, and also to assess any history of sexually transmitted infections that may or could have been affecting their cognition or mentation. So culture and diversity is most important in any healthcare practice, in any healthcare service, among the interdisciplinary team members and staff. So culture is a core element in the delivery of healthcare services and influences how patients and families understand, experience, and respond to health interventions at all life stages, including later years and end of life, which is older adults and seniors and towards end of life. Culture is very important, and we should try to incorporate cultural beliefs as much as possible without endangering the patients. There are some cultural practices that we really cannot, and we'll explain to the patient or the caregiver and the family why we cannot recommend or support them using or doing whatever that routine or ritual may be. But as much as possible, we should try to incorporate cultures, because if we say everything is bad, no, you can't do that, the patient is going to turn off and we're going to lose that relationship that we try to build with the patient and caregiver. Older patients may have traditional health beliefs and a lot of folk medicine. I know Caribbeans, South Americans, Hispanics, there are a lot of health beliefs and folk medicines that we use and believe that they work. And some do work. We're coming to realize that some of them actually do work, and they're being incorporated into modern healthcare treatments. So it's not all bad, but it's not all good either. And as I said, this is an opportunity for education and teaching, and also behaviors that they may be ritualistic, that they've known about, their parents have done before, but may not be helping them. And we should try to, as best as possible, try to discontinue that without making it seem like, you know, it's something bad and they should never have done it in the first place. But again, an opportunity for teaching and education. Culture facilitates and impacts patients' adherence and treatment and recommendations by us, making decisions about healthcare choices, meaning of life, their rituals associated with death and or dying, coping with illness, death and or dying. Culture determines the role of family, who's the head of the household, and the place of everybody else in that hierarchy, sex-related norms, treatment of older adults and children. Usually older adults are very revered, and usually they have control of the household, and children are usually, as my parents tell me, seen and not heard. So that's something you should be aware of. If the children in the household are not able to verbalize their beliefs and their wishes, that's again another opportunity for education and teaching. Religion, most important in a lot of cultures, and spirituality. So religion separate from spirituality. So their religious customs, and then spirituality, what they believe as far as you know, the composition of the earth and environment and climate, and their related rituals that go along with that. Preferred foods, some cultures prefer hot foods over cold foods, and if you try to offer them cold foods, it's a big deal, and they view that as bringing on illnesses. So preferred foods and media choices, where they get their information, use of cultural practices, again, our folk medicine, versus Western healthcare recommendations and treatment. So sometimes our patients will say yes, 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 if it's not explained to them correctly, or you know, they're not sure why we're giving them these medications. They'll say yes, I'll take it, and then later on, if you're doing a pill count or they bring their medication back, you'll find out that they have not taken any, and it's because there was some miscommunication between their beliefs, what they think is for, our recommendations, and their cultural practices, or their preference for their folk medicines. Many older adult patients and community residents at SUNY Downstate are first-generation immigrants with none to minimal health literacy. They may also be the first in their family to have health insurance and access to routine, affordable health care. And they are financially able to afford preventive health care and wellness visits instead of sick care or problem-focused care. So most patients are used to only going to see a healthcare provider, going to the doctor when they have a problem. For us telling them, no, you need to come in when you're not sick, so we could discuss having this test or having this vaccine to prevent you from getting something later on, is sometimes foreign to them. And that's again another opportunity for teaching and education. So preventive health, prevent illness before it happens, instead of treating it once it's happened, when it's maybe more advanced, not treatable, or require more resources, healthcare resources, financial resources to treat or to cure. And they also may be unfamiliar with or mistrustful of Western healthcare practices and treatments. So again, education, treatment, building a trusting relationship between you and your patient or community resident. Patient-centered care, which is what we practice on our service and what our grant is advocating, and we're trying to make it the standard, not just a research format for healthcare, is patient-centered care cannot be provided without an understanding and appreciation of patients' cultures, values, beliefs, and practices. Understanding, appreciating, and incorporating patients' beliefs, values, and attitude prevents stereotypes, prevents biases, facilitates the development and delivery of a service that meets their needs and what matters to them and what matters to their family or caregiver. So it's an opportunity for teaching. We can actually learn from our patients and our caregivers and families, something that we may not be aware of, something that we thought may be bad, that once they explain why they're taking it, we'll be like, oh, light bulb goes off, now I see why they're doing this. And again, always an opportunity for education and teaching. And that's the end of my presentation. Thank you very much. Hope it was informative. These are my references, and now you can continue to the post test. Thank you very much.